to chat, and thanks a lot for the thanks a lot for the great introduction. So as I said, my name is Keerit Tauh. I'm a graduate of the UBC program. I think I saw Ed on the line. I don't know if you can hear me, but he's now off in fellowship with Dr. Vera, having a great time. And yeah, I was actually a late bloomer to the world of aortic field. I didn't realize that I liked aortic surgery until one of the surgeons called me out on it and said, you keep going to the aortic surgery, the aortic rooms, and you're not too bad at it. Maybe you should think about doing it. And it kind of one thing blossomed another. So I actually only really started wanting to do aortic surgery in my 5th and 6th year. So for those of you who are undecided near the end of your time, it's never too late. You can get good fellowships. You just gotta push hard for it. But I'll get right started, and kind of as Abby alluded to, I'm in my 1st year of practice, so I've been thrown straight into the lion's den. And I'm pretty sure everyone can see this, so let's start getting off. So I really wanted to focus my talk on really what should the attending in their 1st year of practice in terms of acute aortic syndromes should be doing, particularly those who maybe have not done aortic fellowships, or even maybe those who've done aortic fellowships and still just need a little bit more time getting on their feet. What is some of the concepts behind it? What is the medical and surgical management? Because those are all fair exam questions. What I don't want to do, and what I will move a bit more quickly through, is the kind of stuff you can read out of a book. The classification systems and so on and so forth. Yes, I'll talk about it, but I'll spend more time focusing on my interpretation and kind of explaining to you how I think. How I think when I get a phone call at 6 p.m. from a cardiologist asking me what should they do, because that was a bit of a wake-up call for me in my first year, and you quickly have to organize what you read in a book and put it onto paper. So we'll talk about acute syndromes, talk about pathology, how you manage them. We'll have a very brief alludment on Malperfusion syndrome because it's so deadly and dangerous, and really there are new things happening in that realm. And then we'll talk about kind of what I had a lot of problems with as a resident before writing my exam is, when do I go for the root? When do I go for the arch? Because I'm sure you guys all have attendings that always do an extended arch and always do a root, always trying to push the envelope. But what do you do when you're in your first 6 months to a year, or even first few years of practice? And then if we have time left over, we'll talk about the future. So we'll start this talk off with a case. And this is a real case that I got a phone call with in my first couple of weeks of practice. And it was a 32-year-old woman who I got a phone call from the cardiologist at 6 p.m. or pardon me, 4 p.m. 30-year-old lady who is cocaine user. She had fever and bacteremia. You get a phone call from the cardiologist looking for endocarditis, but they see this. They see a dissection flap in the ascending aorta is big. She's got good function. Only a little bit of AI and no effusions in the pericardium or in the pleura. So I want to lend you to how to deal with this. You cannot do any good aortic talk without knowing a little bit about the aorta. And this is not a human aorta. This is actually a mouse aorta from my master's degree. And the exterior, the outermost layer is the adventitia. That's where the vasa vasorum exists and where the blood flow and actually the nerves exist. You see the black squiggly lines. Those are your elastic lamellae, which make up your media. The innermost squiggly line is your internal elastic lamella, and then your endothelium, which is the single cell layer, which you can't really see here. So you should know those for your exam. So, I presented something similar to this with our residents at UBC, so Ed will be familiar with this, but, in your head, try to think about who is this person. He has a relation to this person, who also has a relation to this person, and also has a relation to this guy. And essentially knowing where they fall in the realm of aortic surgery and within the realm of acute aortic syndromes, they all have a relation. They all are either succumbed to acute aortic syndromes or were operated on to prevent acute aortic syndromes. And so this is King George II, John Ritter on the left here, Einstein, as everyone knows, and the Terminator. And the last thing I want to do is just put a shout out to the most recent aortic guidelines. They do a really good job on discussing aneurysmal aortic disease. They do a good guideline on explaining how genetics affect aneurysmal disease and actually changing and adjusting our threshold for it. But they don't actually do a great job of explaining acute aortic syndromes and the understanding and the thought process and the physiology behind it. So that elucidate a little bit more. But for your exams, you should know this and the Canadian guidelines just cold. So ask yourself, what is an acute aortic syndrome? Can you define that? And it's something that I really struggled with, and I had to think about a lot myself. The guidelines describe it as a heterogeneous pathologic syndromes that result in a breach in the integrity of the aortic wall. And a syndrome is, by definition, a collection of symptoms or conditions that suggest a presence of a certain disease. And I really think the word syndromes in this field is wrong, because what we know as acute aortic syndromes are many different things. Okay, they present with many different symptoms. They present with chest pains. Sometimes they present with MI, exsanguination, aphasia, coma, many different types of symptoms from a lot of different areas. And sometimes they present with nothing and you get them, just like our lady that we talked about earlier. So I don't think this is a great definition of acute aortic syndromes, and I'll give you the Keerit Tauh definition of acute aortic syndromes that I would definitely not write on an exam, but conceptually this is what makes sense to me. It's a term that denotes acute and often life-threatening, but not always life-threatening, heterogeneous conditions that affect either the thoracic or abdominal aorta that are either result or cause intermedial degeneration or damage. Okay. There are 4 main acute aortic syndromes in the literature. There are more than that, but these are the main ones that you should know. You know, the other ones probably are more of a research-based. These 4 different entities probably have the most varying natural history, and you do treat them slightly different. There are the aortic dissections, ulcers, IMH, and of course, intimal disruption. Aortic dissection is a tear in the medial wall with false lumen flow, IMH. PAU is associated with atherosclerosis, and then intimal disruption. We'll do a bit of a deeper dive into each of these. So intimal disruption is a very localized disruption of the intima. This can be associated with either atherosclerotic disease, or it can be de novo and normal aorta, or even iatrogenic. And you really get that classic bulge that you can see here. And I hope you guys can see my laser pointer moving. You get that bulge that you see here. It's very focused and localized. You may have clot or even flow in that localized area. A penetrating ulcer is almost always associated with an atheromatous plaque, and it's basically, by definition, a penetration of that atheromatous plaque in through the internal elastic lamellae into the media. By definition, a PAU is a pseudoaneurysm because you've gone through the true thickness of the entire wall. As you can see here, the crater invading into that median, into the outer median adventitia. PAUs can have a very variable course. Sometimes they blow out and cause rupture, like you see here. Sometimes they blow into full dissection or IMH, or sometimes they stay stable for years. Okay. Intramedullary hematoma. This probably causes the most angst in terms of its true disruption, or pardon me, definition. Strictly defined, it's a non-communicating dissection characterized by a hematoma, crescentic hematoma, like you see right here. And it's typically thought to arise from rupture of the vasa vasorum. It can be associated with PAUs as well. Here is, 2 scans of patients with IMH. Here's one without intimal disruption. Here's an IMH with intimal disruption. So this could just represent dissection with thrombosis, or a true IMH without a tear. And whether all aortic surgeons believe that truly rupture into the vasa vasorum exists, it's to be determined. Okay, but from a natural history perspective, some of these actually resorb. Some of these dissections, some of these IMHs don't progress onto full dissection. Some of them resorb. And it's very difficult to know and ascertain which one of these do and don't, and we'll talk a little bit about that. And it really has to do with the size, of the aorta, the thickness of the IMH, the presence of any other concerning features like tamponade or new bloody pericardial effusion, etc. And then finally, there's the workhorse, and this is the acute aortic dissection. This is what most of the research is based upon. This is what we know and see the best. And this really results in separation of that aortic wall with an intermedial tear into the outer third, to the outer third of the thickness of the aorta. And you get actually flow through that false lumen. This is a propagation of flow. Usually, the vast majority of the time, there's also exit tears distally down in the aorta. That's the reason why these things don't resolve with just proximal repair, and they often need more extensive follow-up for that. Pathologically, you get medial degeneration, and that is represented in elastin degradation products, extracellular matrix mucin or mucus deposition, and smooth muscle death. So factors that cause these issues with medial degeneration can predispose to dissection, and dissection itself will cause additional medial degeneration as well. So again, because even though these are distinct pathologies with distinct natural histories, they are all still fall within the realm of acute aortic syndromes. We will focus on dissection mainly because it's best well known, and it's probably what you're going to see the vast majority. So we'll go back to our case, and you get this phone call, and maybe this person is not actually in your emergency department. Maybe they're actually in a local regional hospital nearby. And the important thing to do is just to stick to your guns, stick to what you've known. What are the vitals? Get their ABCs. What is the chest pain? What is the character of the chest pain? When did it start? Get your typical history over the phone with pertinent negatives and positives so that you can make a decision. Okay? Give me 1 second here. Sure. Sorry, we've got a visitor. So get your history and find out exactly what the urgency is. And so when I did this, I learned that the lady is hemodynamically stable. She had chest pain approximately 2 months ago. Peripheral and vascular and neurologic exam is totally unremarkable. So is there really a need for emergency surgery? Probably not likely, but when you're in your first couple of years of practice, it is very reasonable to bring this patient into your emergency department or admit them and assess them yourself so you can make an educated decision whether or not. You'll never go wrong admitting a patient unnecessarily as opposed to discharging them home and having them die at home. So I didn't admit her. I let her be, but it's totally reasonable for you to do that, okay? So moving on to classification, we'll move very quickly through this. The most recent classification systems have defined dissection as being hyperacute, less than 24 hours, acute to the 24 to 2 week mark, 2 to 3 month mark is the subacute, and beyond 3 months is chronic. You'll see other time frames. It doesn't really matter what they are because they all act sometimes a little bit differently, but this is what you need to know for your exams. I'm not going to belabor the Stanford A and Stanford B DeBakey dissections. You can read that out of a book, but these are the different ways to delineate them. The whole reason of having a DeBakey versus a Stanford classification is Stanford delineates what is the surgical emergency, whereas DeBakey delineates typically what is the natural history long term. So and that just basically do with your extent of dissection. That's why the two different classification systems are used. More recently, in 2019, the EX group came up with this concept of a non-A, non-B dissection. I'm sure you've heard about. These are kind of an intermediate natural history between type A and type B. They're not as sinister as a type A. They're more sinister than a type B. Their repair is more like a type A, but they're in terms of surgery, but their medical treatment is more like a type B. So this is kind of like this intermediate position. They also have a TEM classification, which delineates what is the type. Is it a type A, type B, or type non-A, non-B, as in where is the entry tear. You then can delineate exactly where that entry tear is zone 0, zone 1, 2, etc. And then the presence of malperfusion. I tend to like this because clinically it makes the most sense. It actually delineates what you may do clinically over the Stanford A, B, and non-A, non-B. And then most recently, the Society of Vascular Surgery exhibited another classification system. This really is more about research. It delineates ABIs at a type A versus type B in terms of where the entry tear is. Your proximal extent relates to your Ishimaro landing zone, so 0 to 12. And then your distal extent delineates your distal extent. And again, you can read that out of a book. I'm not going to spend too much time on it. Conceptually, we just don't know dissection very well. And the reason for that is because dissection literature is plagued with many imprecise and biases. There's no clear definition, maybe until as of recently. It's very poorly recognized and is often post-mortem has a recognition. And people come in very precipitously. We don't have time to get risk factors. We don't have time to get comorbidities. So we don't really know the burden of death, the burden of disease. And you're going to learn this, and you're going to get this when you start going to the clinic. You're going to get patients coming in with dissections or aneurysms, and they're going to tell you that my dad died of a heart attack. And when you actually start asking them what happened to them, it's not a heart attack. It sounds like they had a dissection and they died at home. So all of these reasons portend a poor epidemiologic risk factors for dissections. Quite interestingly, and this is something that the Japanese did, so they took every single patient, probably every single person that died out of hospital. On the way to the morgue, they ran through a CT scanner, and they found that over 8% of people died of an aortic dissection. That is a huge number. And if you think that in North America we're different from the Japanese, I can tell you that probably our vascular health is not as good as them. We're probably even higher than that. So I think it's a very under-recognized burden of disease. In the literature, acute aortic syndromes are uncommon. They say about 7.7 out of 100,000. About half of those are dissection. A small proportion are interval disruptions. The vast majority occur with increasing age and typically are occurring in women. And in terms of your breakdown between type A, type B, vast majority, 60% are type A, 40% are type B. When it comes to the natural history, it all boils down to location. Where is your dissection? How bad is your dissection? Which branch vessels are damaged, not damaged, occluded, true lumen, false lumen. It's all about a location. This is an anatomic problem that results in a physiologic problem. So what vessels are involved? In the ascending aortic arch, you think brain, stroke, coronaries, valvular problems, or rupture and tamponade. In the descending thoracic aorta, this causes malperfusion of the cord, the visceral segments, or the limb. But realistically, any organ can be affected, okay? But what's happening? And this is what I want you to think. And this is what I want you to be suspicious. When you have a patient with dissection, their dissection changes with time and with different hemodynamic parameters. So if somebody starts acting differently than they once did, if somebody's acting differently than the CT scan they had 4 hours ago, you need to be suspicious because different physiologic entities are happening. They can cause branch vessel compromise from static compromise, which is a thrombus forming in the branch vessels. You can have dynamic, where you get prolapse of this intimal septum that occludes the ostium of the new vessel, or you can have a combination of both. And this is happening in real time. Okay, so expect things to change. Here's your typical classic graph that we've all seen about dissections. The surgical versus medical management and type A dissection. The classic 40%, 50% mortality at 48 hours, but usually really it's about at a week, 50% are dead. I think this is probably underestimated. There is some literature that would suggest that 40% actually die at home prior to hospital presentation. So this is probably an underestimation. But this is something you should know and be familiar with. This is more of a contemporary example of our outcomes in dissection with type A versus type B, and this is of course open surgical repair, not TEVAR repair. So type A does much better with repair, surgical repair, whereas type B does better with medical management. And again, that's slightly more older data that's not in the realm of TEVAR. So 1 to 2% mortality for your first day, and then about 50% dead at a week. The things that kill you are problems with the aortic valve, problems with your coronaries, rupture like tamponade, or stroke. Type B has an unappreciated mortality at 30 days, about 10%. That's a lot of people dead at 1 month. And that's happening because of visceral ischemia, rupture, and organ failure. Okay. But again, I don't want you to just think and be able to list these in a box. I want you to actually think. This is what acute aortic insufficiency looks like in dissection. This is from a young guy, I think 40-ish years old, that I had about a month ago. So you get massive AI. Oh, come on. Oops, you get massive AI forming from prolapse of his intimal septum down into his aortic valve. This is another, not my case, but here you can see that there's fluid around the pericardium with collapse of your right ventricle. All of these should be tipping you off. You should be able to notice these on echo, not just thinking about it in your brain. This is how it actually presents. And then here's a thrombosed coronary artery. So here you can see the dissection flap goes into the coronary. The false lumen thrombosed and occluded the coronary artery and killed the patient. So be looking for these signs of ischemia. When you start to see this, you should be thinking anatomically, the dissection is in my coronaries. What do I do about it? How should I fix that? That's going to translate into surgical repair. And then finally, here's a video.
Okay, so this is a type A dissection in a 41-year-old gentleman with polysubstance use. He presents with a root aneurysm and a division 2 dissection. You can see here he's got partial rupture being contained by his PA. Here's the intimal defect, extremely large. The PA is extremely close to it. Here is essentially where the contained rupture is. Not, I put very little force to go through there, and he would have ruptured right there. So we're going to end up doing a root hemiorrhage with this guy. Thanks so much.
So that there is why this guy presented with tamponadic shock, and he actually ruptured when I opened up his chest, and we managed to get him a bypass pretty quick. So that's what kills you, and that's what you should be prepared for to deal with anatomically. Pain. Pain is the major presenting complication in patients with dissection. The reason pain occurs is because the neural innervation within the adventitia gets stretched when the aorta dissects. The aorta increases by size by around 15%. So that increase in stretches those nerve endings, and that's where you get that tearing pain. People come in with hypertension, either pre-existing or from renal compromise, catecholamine drive. Those that present with hypotension and shock, you should be very wary about. If you come in with a normal blood pressure and you have a dissection, you should be wary. You should be thinking, why? Why does a person who should have hypertension not? And you should be thinking of the things that like heart failure and coronary dissection that kill you. And then finally, you should be thinking about mechanical complications. How does this person rupture? Do I have AI, etc.? Okay. Remember, presenting features of an acute aortic syndrome is extremely varied. Very quickly, for completeness sake, we'll talk about the aortic dissection risk score. This is more about dissection of it. There are 3 categories that are high-risk conditions, innate conditions, features, and physical exam. It's IRAD database validated. Essentially, the presence of 1 or more of these conditions put you at either intermediate or high risk of having a dissection. So it's important to rule those out. Here are your risk factors for dissection. They're typically either environmental or acquired, things like smoking and stimulant use, endogenous or genetic, like connective tissue abnormalities, and then other comorbidities like dyslipidemia, iatrogenic, so previous heart surgery, previous cath, so on and so forth. We'll spend a little bit more time in genetics because I think it's something that's blossoming in the field of dissection, and it's more and more apparent. About 20% of all cases are presenting or do have a genetic component in it. I think that might even be higher. But the types of genes that are involved, and again, this is about thinking, they are abnormalities in either your connective tissue, your smooth muscle cell physiology, or cell signaling. If you have a gene that affects those pathways, even if it's not on this list, and you have somebody coming in for an aneurysm, I want you to think, can this be affecting the aorta? Should I be more aggressive in their aneurysm or not more aggressive in their aneurysm? And so on and so forth. Typically, those who have genetic abnormalities are younger in presentation, and they also have associated with bicuspid valve. Okay. Clinical workup, you know, again, the big things you need to rule out are MI and pulmonary embolism. We won't spend much time on this. Really, imaging and clinical exam are the key. You can get a D-dimer that's really just there to rule it out. Troponin might talk to you about if there's coronary ischemia. And then really the other products like smooth muscle cell heavy chain, matrix metalloproteases, elastin degradation products, those are more in the realm of research and clinically just really not ready for prime time. Get a chest x-ray. Chest x-rays have been demonstrated to have very poor sensitivity and specificity. What you need is a CT scan. And if you haven't got your CT scan yet, you want a gated CT scan of the chest, abdomen, pelvis. You want to know what your kidneys and your femoral axis are like with a 90-second delay. You want to see what your flow through your false lumen is. And all dissection protocols should also have CT non-contrast. So if you're going into centers that don't have a dissection protocol that includes a delay, a non-con, and an arterial phase, that needs to change because it does affect and change management. Echo is useful to rule out the dangerous things like tamponade and heart failure, but really CT scan is the most important thing. Okay, here's just a figure that delineates the workup. Okay. Management and the most recent guidelines, they talk and discuss about this. They actually put it on paper. First line therapy is beta blockade. I usually target a heart rate of less than 60. Once my heart rate is less than 60, then I target a blood pressure of less than 120, 110. I believe the guidelines say less than 120, but I go as low as I'm not going to make them their kidneys hurt. And again, you always use a beta blocker first, then you use a vasodilator agent second. Okay. Treat their pain, get their catecholamine drive down, and these people need to be in monitored settings, if not directly to the operating room. Indications for an operation, you guys know this. I won't belabor too much of the point. If there's a type A, you need to operate. Type B, the classic indications probably for intervention are failure of medical management, malperfusion, impending rupture, expanding aortic diameters, etc. But we'll talk a little bit more about this in later. Conceptually, I want you to think about dissections as this. Your goal of repair is to promote true lumen flow, induce false lumen thrombosis, which is positive aortic remodeling, and prevent short-term and long-term complications. That's the goal. Obviously, the first most important thing is true lumen flow and induce false lumen thrombosis. Preventing late complications, if you can do that, then great, but your most important thing is the first, okay? Type B is a little bit more difficult. It's a little bit more nuanced. It's not just see a dissection, go in and grab it like a type A. It's a bit more nuanced. If you have a complicated dissection, which is the classic indications, you go in and you repair, particularly if it's feasible with TVAR, okay? If it's not feasible with TVAR, then you have to start thinking about potentially open surgery, which is a very high morbid operation. Most commonly, you can usually treat them with TVAR either through staging or through direct TVAR. If you have an uncomplicated dissection, which is probably a bad term to use the word uncomplicated, but has high-risk features on CT scan, then you ask yourself, is it favorable for TVAR or not? If it is favorable for TVAR, you should probably consider doing it. If it's not favorable for TVAR, you should probably look at medical therapy. Okay. Ideally, endovascular repair in type B is the modality of choice. Okay. What are those high-risk features in type B? And a lot of them kind of stem and come out from the Extend series, where they're looking at subacute type B dissections, where they saw a reduction in aortic-specific mortality and a positive aortic remodeling with TVAR when performed in the subacute phase. Okay, where they saw improved false lumen thrombosis, improved remodeling, and reduced aortic expansion. Physiologically, these high-risk features that we say on CT scan, these high-risk anatomical features, what they talk about is they are delineating anatomic high risk, so extensive dissections and a pressurized false lumen. Those are your large entry tears, large initial diameters, large false lumen diameters, a compressed true lumen, and a partially thrombosed true lumen. All of those delineate a pressurized false lumen or a highly extensive dissection. That's what high-risk features means, okay? Here's your contemporary treatments of type B dissection with medicine versus surgery, which are not great. And then we'll just get into a little bit of malperfusion syndrome because it's quite a dangerous thing and it's a new blossoming field. Malperfusion syndrome is a both clinical and radiographic diagnosis that is defined by an inadequate blood flow to the end organs related to obstruction of its aortic branches. Okay, most commonly this is existing in the kidneys and the extremities, but of course it can happen in the mesenteric coronary or any vessel for that matter. The prevalence is about 33% of all dissections have some form of malperfusion, and when they do occur, mortality is high. It's in around the 30%. Okay, and compared to those without without malperfusion, mortality is around 6%, and those with it, again, 30%. Central aortic repair typically improves, and this is a very small series, but it typically improves malperfusions in those with renal malperfusion and extremity malperfusion. It is not very good at improving intestinal or cerebral malperfusion, which might tip you off to do potentially a more aggressive aortic repair or extended aortic repair like antegrade T-bar and so on and so forth. Okay, and we'll get into a little bit of that later. Again, this is just showing mesenteric malperfusion, very bad. And this is where you may have heard the Michigan malperfusion first syndrome. This is where that concept came from, is how bad mesenteric ischemia is. The more malperfusion that you have, the worse it is, which is quite intuitive. Okay, so we'll kind of move away from the theory, and I want to spend a little bit more time on the actual surgery to explain to you really now when you get into the operating what happens. So this is a case of mine. I had a 55-year-old guy, came in hemodynamically stable. He was diagnosed with acute type A dissection. I got a TTE, got a CT scan. He's got his tearing back pain, and I get a cardiology. So I asked this guy to be sent directly to the operating room from the opposite hospital. Okay. So the main principle, and you may have seen this before, is, and I hope you've been told this, is bring the patient out alive. Bring the patient out alive. As much as you hear aortic surgeons sit here and talk to you about doing root zone 2 arches for everybody, that's not what we actually do. That's not what we did in Penn. That's not what Toronto does. That's not what Houston does. That is not what everybody does. Okay, bring the patient out alive. You have to have an alive patient to have long-term follow-up. Okay, so that means stopping malperfusion, stopping tamponade, rupture, aortic insufficiency, and stroke. You may require more extensive aortic repairs to do such. The goal is to get an alive patient. Conceptually, we simply utilize the heart-lung machine to cool the patient down to allow us to perform circ arrest. Why do we circ arrest? Because an open distal anastomosis allows us to do two things. It's an easier anastomosis. We can actually see and reconstitute the layers, and it's allows for a more safe, extensive repair. I can take out more of the arch. I can take out more of the pathology. A clamped distal anastomosis is not standard of care anymore as it was many, many, many years ago. So use the bypass machine, cool the patient to allow you a bloodless, extensive repair for a hemiarch. Okay. So we'll talk a little bit about the cannulation strategies as well, and I'm sure you've probably seen some of these. So you have your axillary artery, which is probably a pretty common go-to. Potential advantages of this is it allows you very easily to do antegrade cerebral perfusion. Typically, the axillary artery is free of disease. It allows redirection of blood flow into the true lumen. Disadvantages, conceptually, they talk about arm overperfusion, whatever the heck that means. I don't know what it means. But very real. You can have brachial plexus injuries, and I do see patients in the office with that. And it's slow. It takes time to cut down. It's not very precipitous. Okay. Here's just a quick reminder of a brachial plexus and typically what it looks like. All of these parts of the brachial plexus can be injured and may be injured during axillary cut down. Femoral, again, not a bad cannulation strategy. Certainly works in a pinch. I don't typically do it, but it can be considered. Guys like Dr. Chu, I know, sometimes are actually adding a femoral cannula to improve perfusion to the lower body. It's not in my practice to do that. I often will use the direct aortic, which I'll talk about later. But But if you have a patient who you can't use their axillary artery for whatever reason, it's dissected, it's a redo, you don't have time, femoral is still a very reasonable approach. Okay. The problem is that because you're cannulating distally and blowing back proximally, the risk of embolic stroke from retrograde perfusion is higher. You have a higher risk of malperfusion because, again, you may or may not be perfusing the true lumen. Okay. Monitoring at an absolute bare minimum. Have a right radial artery if you're planning on doing axillary cannulation or nominal cannulation, or perfusing antegrade. You should probably have a femoral artery blood pressure because your right radial might comp out. You might maybe consider even a left brachial. You need cerebral oximetry, bladder, nasopharyngeal temperature monitoring, and TE. Okay. How you set up your pump. Don't be shy. You want to Y off your arterial. I also Y off my venous because I do RCP. But always Y off your arterial gives you options. Okay. And when you initiate bypass, watch your line pressures. Watch what's happening on TE. Watch the cerebral oximetry. Because remember, when you go in bypass, you've now changed the anatomy of the dissection. It no longer looks like your preoperative CT scan. It's going to be different. And you have to figure out why and figure out how. Okay. Other cannulation innominate, for completeness, I've included in here. I don't like clamping the innominate in type A dissection. Maybe I'll do it for aneurysms, but not in dissection. I'd sooner just do a direct ostial. And then finally, for me, I do direct aortic. That's my cannulation of choice, where you essentially take a needle, place it through the adventitia into the true lumen under either ultrasound guidance or CT guidance. You pass a wire through that needle into the true lumen, put an IOPA or some sort of arch cannula down, and then you have immediate reperfusion of your true lumen. Okay. It is very important, if you're going to do it this way, you must know you're in the true lumen. You need to have good echocardiography who can see your wire and they're cooperative and do it. You have to confirm the true lumen. You have to confirm flow in your DTA. You have to confirm flow in your carotids. You must know you're in the true lumen. Otherwise, you'll be producing false lumen entirely, which causes a major problem. Okay. And then finally, for completeness sake, again, there's transapical. I've never heard of anybody doing it. I probably may not even mention this on an exam, but if they push you towards saying it, you can maybe suggest it as a last-ditch effort. The important thing is if you do use it, you put a purse string in the apex, kind of the same way you do a transapical TAVI, and you advance your cannula through the aortic valve. That's really the key points to say. Okay. Your cannulation strategy just depends on both the patient factors, so what their anatomy is, but also your surgeon factors. Are you comfortable with it? Okay. We'll talk very briefly about brain perfusion. And really, the whole point of cooling is to alleviate the consequences of hyperperfusion. You're using cold to buy yourself time. You're also using your cerebral perfusion strategies, either RCP or antegrade, to again buy yourself more brain time. Okay. Very quickly, typically we monitor brain in the nasopharynx and esophagus because that's probably most similar to your brain temperatures. So I always have a nasopharyngeal or esophageal or typically even a bladder temperature. The different perfusion strategies are just pure circ arrest like Epidemiology does, or hypothermia with ACP and RCP. I use a combination of both RCP and ACP together. For completeness, these are your classifications of hypothermia, which I know you guys can read in a book. Here's an important concept, and it's about a concept of electrocerebral silence, and it's looking at what degree of cooling results in a quiet brain, an EEG silence. Typically, we're seeing for the vast majority of patients that occurs at around 18 degrees, but actually more importantly than temperature is actually time. It's time to EEG silence. The longer the period you cool for, the more reliably you get an EEG silence. So when you're cooling for 45 minutes, about 90% of patients have EEG silence. So I actually cool more based on time than I do on temperature. Okay. And then, temperature is time. So when you're at 15 degrees Celsius, you're safe. Pure circuit rest time is around 30 minutes. When you're at 25-degree temperature, it's about 15 degrees. And again, that's just literature from old literature that you got to know for your exams. Okay, same thing delineates here. Pure circuit rest is safe for less than 30 minutes when you're at 18 degrees. Gives you a truly bloodless field. Takes a long time to cool down and warm up, and probably more coagulopathy, probably more inflammatory response, and probably less time, and probably less safe. Your adjunctive therapies or your ACP. So integrated cerebral perfusion. There's a bit of controversy on the terms of whether or not you require an intact circle of Willis. Typically, ACP is performed using either the right innominate, the right carotid or right innominate perfusion. You can do that with a cannulation of the axillary or a balloon tip catheter. Usually, your flow rates are around 10 cc's per kg, and I bring my right arm pressure up to about 60. Even in the absence of a complete circular Willis, you still actually have middle cerebral flow on the contralateral side. RCP, or retrograde cerebral perfusion, how I do that is I cannulate my SVC in the usual fashion. I have a stopcock on my SVC cannula, and I just use my cleavage line to run blood in through my stopcock. And then it provides retrograde flow. I flow to, personally, I use a CPP no higher than 18, and I cool at around, and I run around 250 cc's per minute. And really, it serves to flush emboli and flush debris out of the brain. Just a month ago, I literally saw a piece of clot come out of somebody's left carotid artery. So I do think there is certainly some value to it. There's debate whether it's nutritive flow and oxygen flow. I would say that there probably is not, based on the literature. Anecdotally, when I see that blood come back in my face, it is dark. It is not that bright red blood. It is dark. So the oxygen is going somewhere, and I don't know, no idea where it's going, but it's going somewhere. What enables you to do RCP is that the brain is a valveless venous system. That's how you get good bilateral shape. The safe approach. And if you are somebody who's not comfortable with dissections, maybe you have not seen many at your center, the safe approach is 18 degrees Celsius, use your axillary artery, put an 8 or 10 millimeter graft on, snare your innominate, and perfuse ACP. If you're going to deviate from that, you better be damn well sure you know what you're doing. You better be damn well sure you've seen enough of it to be comfortable with it. Okay. If you're in an urgent rush, cannulate femoral, and that's totally fine. And stick some balloon tip cannulas up your innominate if you have to. Okay. The most recent guidelines do give you some direction on this. Class 2A indication for either cannulating directly, using some form of cerebral perfusion, either RCP or ACP, and using the axillary artery. So either of those is reasonable. One of the concepts that I struggled with as a resident is, when do you go after the root? And I'm sure you've all seen surgeons that are very aggressive, some surgeons that are not aggressive, that avoid the root like the plague. And I was never sure what to really do with it. The simple answer for someone who is perhaps not as comfortable with a root surgery is, do you have a tear? If you have a tear in the root, you have to fix that tear. Whether that means doing a hemiacute because the tear is only in the non-coronary sinus, or doing a formal root because the tear is somewhere else. Do you have a truly aneurysmal root? Is that root 50 millimeters or more? Is 45 millimeters or more, and you are too scared to address the root? That's fine. And then also, if you have a genetically, somebody who comes in with SMAD3, somebody who comes in with Marfan syndrome, I would always err on the side of doing a Bentall over doing a valve sparing, especially on your exams, especially in your first few years of practice. If you're very comfortable doing a valve sparing root, then do it. Or even a hemiacute. But always err on the side of doing a Bentall. I have done valve sparing roots in dissections. It's very nerve-wracking, and I seem to have gotten away with it. But again, I will always err on putting in a mechanical valve if I've got a young patient that I'm concerned that the tissue quality is not there. Okay, bring the patient out alive. That's the most important thing. And then there's the valve, and again, the valve adds, The valve is going to be scary as well. And it all just boils down to, again, bring the patient alive. Do you have a valve that will sustain life? Or are you concerned that the valve may be compromised in some way? If any of those factors are present, address the valve. Sew in a bioprosthetic valve. Worry about that bioprosthetic valve 15 years from now. Don't worry about it now. Times to address the valve is A, do you have an aneurysmal root and you're not comfortable doing a valve sparing, so you got to throw the valve in that bucket? Do you have a stenotic valve, calcifications valve? Do you look down at that thing and say, oh, geez, yeah, that thing's not going to last very long? Is the leaflets actually destroyed from the dissection? And then what is your AI situation? Do you have severe AI? A lot of times, like you saw in the previous echo, you will have severe AI that gets better with aortic root repair or with an ascending replacement. But if you have any concerns that you will not have a durable repair, replace the valve. Have an alive patient. Okay. If you do decide to spare the valve, always resuspend the commissures. So just above, put a pledget stitch from inside to outside, resuspend the commissures. That prevents future dissection of that valve and dropping an AI of that valve. Okay. My technique that I had learned, or I should say my technique, but rather the technique that I utilize, is I create a neointima, which I simply take felt in the areas that there's dissection. I put the felt inside within the neointima. Sometimes I add a tiny amount of bioglue just so that it makes it easier so things don't move around. And then now I've got a nice robust aorta to sew to. And again, I always still do my resuspension. Yep. So as I said, guiding principle, do a safe operation and get the patient to survive. If the tear is going into the left coronary artery or the right coronary ostia, there's a couple of things you can do. You can either primarily repair it, which is dangerous. You can put a Teflon button or a pericardial button. So basically you make a button and you sew it in, or do a bypass. You do bypasses every day. You know how to do it. Get some vein, do a bypass, save the person's life. Worry about the rest later. Okay. So we'll move on to another case. And this will kind of illustrate a little bit about the extent of repair. So you have a 32-year-old woman with acute type A dissection who presents with a stroke. In the OR, I plan to do direct aortic cannulation, plan to do a hemiarch initially. When I open, I see this big intimal tear in the arch that goes inside the left common carotid. What do you do? What is the approach and the extent of repair? So your basic repair technique, hemiarch, you do a single vessel, a proximal arch, 2 vessel, or do you go and do a total arch? Do you also add an elephant trunk or an antegrade deployed stent? Okay, if you're getting into this areas, call for help. Okay, call for help. The hemiarch is an excellent repair technique. Okay, you can do a very good aggressive hemiarch and exclude, I would say, the absolute vast majority of tears in your practice. If you can do a hemiarch well, you will be fine. But what happens when you do have that tear that goes into the carotid, or a tear that you cannot get access to with just a hemiarch? That's when you need to start looking at doing multi-branch vessels. There are a lot of different products out there. Do not learn them all unless you want to be an aortic surgeon. Even if you want to be an aortic surgeon, do not learn them all. Learn a few products that your center has, be comfortable with them, know their sizing, and know how to use them. Forget about all the rest. Personally, I like the Sienna graft because it can do anything. It has an elephant trunk if you need it. It has a cuff if you've got an aneurysmal arch, and it's got plenty of branches that you can use. All right. The other nice thing is it's got radiopaque markers that I can come back after the fact and do a T-bar if need be. There's also the Thoraflex, which I'm sure you guys have heard about, which is now approved in Canada. It's got a built-in frozen elephant trunk. You better have a good reason to use that built-in elephant trunk, because the risk of spinal cord ischemia in frozen elephant trunk in acute type A dissection is not negligible. You should be wanting to fix something specific like a Malperfusion syndrome. Okay. And then you have a myriad of different grafts that have multiple branches and so on and so forth. You can make your own grafts, but these all just add time and circ arrest time. More recently, I think they just put the first one in Victoria and all of North America, is the Avita. Again, this is just another brand with a frozen elephant trunk built in. okay? So in this lady, a tear going into her zone 2, into her carotid, I had to do a zone 2 arching. And the rationale for that is I cannot exclude that tear, and she's presenting with a stroke. Okay. If I'm not prepared to do a zone 2 arch, maybe I've just got my axillary artery cannulated, maybe I plan to do RCP, and now my circuit rest time is going to be longer. No problem. You've already widened your arterial line, because that's what every good aortic surgeon does in a dissection. You just grab some balloon tip catheters, you put it up your carotids, now you're on ACP. Okay. So we'll move a little bit into the frozen arch concept and the antegrade TVAR deployment. And really a lot of this information is coming from the type B dissection world, where we know that based on instead series, that TVAR in the subacute phase is starting to become the gold standard of treatment, because you're having positive aortic remodeling, and that's starting to translate into likely mortality benefit. In type A, the role is still controversial because you still have concerns for spinal cord ischemia. And I would say total endovascular repair of type A is really just reserved for expert aortic centers, arch branch grafting, and those who are non-surgical candidates, right? But after central aortic repair, 90% of patients will still have false lumen flow because of all those additional entry and exit tears, okay? And a lot of them, particularly with visceral malperfusion, will still have them continue. Just like we talked about before, malperfusion is a terrible thing. If you are starting to see this, you should start considering antegrade stent deployment, okay? There's been a series that looked at in patients presenting with malperfusion syndrome, those who get antegrade stent deployment versus not. We're starting to realize that those with antegrade stent deployment do better in the setting of malperfusion than those that do not. So this is something that you can be considering. Abby will ask me about the AMDS device. I think the AMDS device is a lovely device. It's not something that I would use in the vast majority of my younger middle-aged dissection patients. I think it's the type of device that I'd use either A, if I'm not an aortic surgeon and I have malperfusion, or B, I just want to get a hemi-arch done because the person is so sick and I don't want to do an extended arch repair, but I might have concerns of malperfusion. That's when I'm probably using an AMDS device. But I think the data in the literature on it versus an antegrade deployed stent is probably still better to do an antegrade covered stent. Okay. But again, you have a much higher spinal cord risk with antegrade deployed stent. You get 0 with an AMDS device, well, near 0, I should say. This is just basically looking at those who received stenting of their DTA versus not, and it did show an improvement in those who received stenting. Okay, and stenting and putting an antegrade deployed stent is simple. It is a cinch. If you have deployed more than 2 TVARs in your life and you know how the handle works, all you do on circ arrest, you go, you look where your subclavian is, you position your stent right at beyond the origin. It can be even a little beyond it, doesn't matter. Beyond the origin of the subclavian, you quickly release it and you're done. Personally, what I do is I actually still put a wire down, and the IFU would still suggest to put a wire down. I actually get anesthesia under circ arrest to confirm my wire is in true lumen, because I don't want to deploy this in false lumen, because you can't totally see around the corner. And then if that's all confirmed, then I deploy it. Okay. And here's someone who had a malperfusion syndrome with a very small false lumen. With the antegrade deployed stent, he had quite a good resolution of his true lumen. Okay. And I know I'm moving very fast, and you probably have some questions, and we'll take a break before we get into kind of the more feature stuff. I'll talk a little bit about the concept of malperfusion first, and this is something that's been pioneered probably by Himanshu Patel, Bo Yang out of Michigan, and this is the concept of patients who come in with bad malperfusion of certain types. Is it better to take them directly to the operating room, or is it better to fix their physiologic derangements with then staged central aortic repair. It avoids using cardiopulmonary bypass when the person's already physiologically surged up. It avoids persistent branch vessel obstruction that still persists even though you have central aortic repair. Typically, they do this by endovascular fenestration of the septum or actual stenting of the offending vessel. The important concept that you need to know and take away is, if you want to be as good as the Michigan guys at fixing malperfusion at doing malperfusion first, you have to do it like them, which means they literally put pressure catheters into each of the aortic branch vessels of concern, and they measure the dP over dt. They measure the change of pressure. And what they're looking for is a change of pressure of greater than 15 millimeters of mercury to delineate that that is a malperfused branch. If you're not doing it, you're not doing it like them, and you won't get the results like them. This takes a huge amount of resources to do, and that's why malperfusion first syndrome, I think, is very difficult at a lot of centers to adopt, but we'll go through it. Typically, they say if you have isolated renal malperfusion only, they're not typically a candidate for delayed approach. These are for the patients if they have coronary or cerebral or spinal malperfusion, you do aortic repair first. If you also need an absence of rupture, tamponade or coronary ischemia, like we talked about, then you can do the malperfusion. So, acute type A, if you're unstable, then you go to central aortic repair. If you have visceral extremity malperfusion, yes. Arterial obstruction, yes. Then you can look at your endovascular repair. Anything else, you go to the OR. Okay? The types of procedures they're typically doing most commonly are both branch vessel stenting and fenestrations. These are highly complex endovascular procedures. Delayed aortic repair typically happens in about 48 hours. Okay? And in that time between stenting and fenestration, they have very, very tight blood pressure control and very minor sedation. Typically, these patients are actually extubated.
125 grams.
Any burning questions? Okay, so, and again, this data is a little bit biased because clearly patients who there's a selection bias here. Patients who have malperfusion but don't get the reperfusion syndrome, or pardon me, the reperfusion strategies, so the fenestration and stenting, they have a high mortality. Those who do get it have a reduction in mortality. The reduction in mortality is amazing, but remember, these patients are also self-selected to be those who do better. Okay, so there is a selection bias here. Some of the new frontiers in malperfusion syndrome, some patients and some people are doing PCI for coronary malperfusions. That's some crazy things happening in Japan and China. Some people are actually stenting in your carotids if you're coming in with strokes or one of your carotids being out. We do know that with direct aortic cannulation, your carotid flow is improved as compared to axillary. That's the reason why I do direct aortic. And then, of course, those with visceral malperfusion, they are doing malperfusion first. There is a risk of waiting. And in the earlier trial, in the earlier series of their patients in the first decade, they did have a risk of rupture of around 11% before delayed repair. That's very high. 11% of patients are rupturing while waiting for surgery. And that's in the first decade. In their second decade, they did not see those that morbidity. Obviously, they're getting better at the technique. But remember, there is, in those centers that don't do this all the time, you can probably expect a similar learning curve in terms of what happens to your malperfusion first patients. Okay. So here's a quote by Albert Einstein. I'm sure you've heard. And he says the definition of insanity is doing the same thing over and over again and expecting different results. And I think in cardiac surgery, we tend to do the opposite. And one of my mentors, Dr. Hussein Shayan, kind of amended it. And he said that in cardiac surgery, the definition of insanity is doing something differently over and over again and expecting the same result. And why I think that this is relevant in malperfusion is that if you want the outcomes that Michigan has,